Welcome, welcome. We're going to give it till just about 5 after 6:30. So just a few more minutes here. Get everyone here, and then I'll hand it off to wonderful Dr. Melinda Henne, who is in our Minneapolis, our brand new Minneapolis clinic right now. Denver, San Francisco, New York, LA, lots of places where we have clinics. Welcome. We're so happy to have you. Welcome. Okay. Dr. Henne, if you are ready, let's hand it off to you. Quick introduction. Dr. Henne is one of our fabulous REIs. She is, I don't have her bio in front of me, so I'll let her do a better introduction of herself, but she is, well, all of our REIs are very educated, but Dr. Henne goes above and beyond. She's even pursuing her master's right now. She's wonderful. She is one of our traveling REIs right now. You can find her in our brand new Minneapolis clinic. We're so excited to have her with us tonight to lead this conversation. As the presentation goes on, feel free to drop all of your questions in the chat. We have a few team members with us who are able to answer a lot of your questions. And then at the end, we'll take a handful of them and give them back to Dr. Henne to hopefully help answer all of your burning questions. So without further ado, Dr. Henne, let's take it over.
Okay, good. I have power to unmute myself. Last time I did one of these, I did not have that power. So I feel super powerful tonight as we get started. I don't really feel like I have to do much of an introduction. I have been doing fertility work since 2002. So I've been around for a little while, and I'm really happy to be able to be part of the Kindbody team, because since I've been doing this for a while, I like that we do things at Kindbody differently than some of the way I learned and started doing things about 20 years ago. So when I do these Fertility 101 talks, I really start out kind of with some very basics and take people back to, I call it junior high health class, and then we move and get more advanced from there. So I think we can probably start moving the slides. So this is just a picture of, this looks like one of our New York Kindbody office. One of the things I really love about Kindbody that is just so different than other places I've been is Kindbody started out with just a big mission of, we want to make reproductive health care and fertility treatment accessible for everyone. So by making it accessible for everyone, it's not just women have to worry about this, or women who are partnered with men, but it can be women who are partnered with women, it can be single women, it can be men who are partnered with men. But also, a lot of times people hear about fertility things and they think about, cost, and it's super expensive. And so by partnering with employers to have fertility services added as an employer benefit, it can actually sort of increase everybody, access to being able to get the evaluation treatment that they deserve as they want to build their family. So we can go to our next one. So this is a big slide that says, here's what we do. So at Kindbody, we do everything fertility related, including assessments and evaluations. We do consults in person as well as virtually. We can do fertility preserving things like egg or embryo freezing. Obviously, the standard sort of treatments with IUI, which is intrauterine insemination or artificial insemination, IVF. We have donors, eggs, donor sperm. We can even assist with surrogacy. We do genetic testing. We also we have a team of gynecologists who works with us. So at Kindbody, we can also do a full service of gynecology care. And then one of the things that makes this really unique and different from a lot of other fertility clinics is we try and do, like, we call it 360. It's holistic health. So we do have services to help with wellness, nutrition, some of the psychological aspects and the challenges that happen when people are going through fertility evaluations, as well as services for our rainbow community. So we talked about, our mission. And one of the most important things I think that we can do for anyone who's seeking to learn about themselves is to give them knowledge. Knowledge is power. And so sometimes people will go to a fertility clinic only because they're having fertility problems, but we really like to be available so that you can come to our clinic when you just want to learn about yourself and learn about your own fertility. It is, a harsh reality of life that time is not on our side as women. And so as we are growing our careers, sometimes we forget to think, stop for a moment and think about all the other things we want to have in our lives, like our families. And so we provide information so you can learn about your own fertility potential, kind of get an idea of what your timeline is, and just have that access and make it just sort of friendly and inclusive and warm and inviting. We don't want people coming into our office going, oh God, not the doctor's office again today. We want you to feel like you're coming in and you're, part of our team, part of our family. So Fertility 101, kind of why we do these things, is when we go back to junior high health class, we were told how not to get pregnant. Women went through college, and men too, go through college, don't get someone pregnant, don't get pregnant. It's all about how not to conceive, but no one ever spends any time telling people what you need to know to be able to get pregnant and give you information about what that's going to look like and what the journey may be, that you'll experience, because the path is different for everyone. And sometimes people think, oh, I've spent all these years trying not to get pregnant. I want to get pregnant this month. And they don't really understand kind of where to begin. They think, oh, stop my contraception, things will just work. But there's a lot of things that go into it. So we just want to make sure everyone knows what's necessary. So for women, the biggest thing we do have to think about is the harsh reality of age. I'd love to stop the clock. Honestly, at this point in my life, I'd like to turn the clock backwards. So for women unfortunately are born with all the eggs we're ever going to have in our lifetime. Our maximum number of eggs is before we're even born. And it's kind of a harsh reality and cruel fact that we lose more than half of the eggs we're born with before we even hit puberty. And there's a continual loss over time. So it is important to start having these conversations even before you are ready to conceive, just so that you know where you are and what that timeline may look like for you, because it will be different for everyone. So let's start at the beginning. When we are born, women have about 2 million eggs. By the time you have your first period, you've lost over half, actually 3/4 of them, and you're down to about 400,000 eggs. So every single month, people think, oh, I ovulate one egg. I have 400,000, so I have 400,000 months. But unfortunately, that's not the case. Every month, a group of eggs wakes up, and one is chosen to be a dominant egg that ovulates. And then hundreds more will actually provide support for the one. And so some people think, okay, I'm on birth control pills. I'm not ovulating, so I've got everything put on pause. Well, unfortunately, that although those eggs may not be waking up every month to prepare to ovulate because they're not getting that hormone signal, they are still kind of developing and getting lost just without that one ovulating. And so pills, no pills, whatever whether you ovulate regularly, whether you don't ovulate because of hormones, whether you don't ovulate because of a medical condition, we're still losing about 1,000 eggs every single month. So that gives us really about 40 years of a maximum fertility window. And I say 40 because that's assuming like a first period might happen for someone when they're about 10, and a last period will happen when they're about 50. But that will be variable for everyone. And that 1,000 eggs we lose in a month, for some people it may be 900, and for some people it may be 1,500. So let's talk about eggs and age. Everyone has this magic number in their head. They hear 35, and there's a terrible diagnostic code for 35 called elderly gravida. And now that my age is inversed from that 35, I don't like the word elderly at all. But we talk about 35 as the age when fertility declines. And this was really an arbitrary number that was picked. It was really picked because once upon a time, when we were looking at amniocentesis and looking at miscarriage rates with amniocentesis, the risk of a miscarriage was about 1 in 200. Well, the risk of having a child with Down syndrome after the age of 35 is about 1 in 200 when you're 35, and it gets higher than that as your age increases. So this line was drawn to say, okay, and it's sort of confusing, but it's like, so when risks balance each other, so that people said, okay, 35 is this arbitrary cutoff. What we know that is at age 25, about 25% of women who are ovulating and having intercourse or having exposure to sperm and have open tubes will get pregnant in any given month. By age 30, that 25% has decreased to about 20%. At age 35, 15% of women would be able to conceive in any month that they're actively trying. And the decline in fertility rates per month increases at a faster rate after age 35. At age 37, the chance of conceiving is about 12%, and then it really declines more significantly, so that by age 40, the likelihood of conceiving in any 1 month of trying is about 8%. So it's a constant decline, but the decline gets a little bit steeper in the 30s, in the late 30s. But 35, I feel like, is this arbitrary sort of cutoff number because it's not like a black and white, like a light switch. It's a slow decline over time. And then, unfortunately, there will be a small number of women whose decline in fertility is even faster. And so while I might say 35, 15% of people get pregnant in any month at age 35, that doesn't mean each individual woman has that chance of pregnancy, because there will be some women who have a more rapid decline and they might have what's called a premature diminished ovarian reserve. And we'll talk about ovarian reserve and the testing for that in a little bit later. So I'm going to try and answer a couple of questions that I see here really quickly. So Sydney said, does birth control affect fertility? And the answer is no. It doesn't help preserve your fertility, but it also does not hasten a decline in fertility. And then Payal asked about how do you lose 1,000 eggs a month? It's because there's this whole group that wake up. One of them ovulates, and then all of the others are providing hormone support for that one that ovulates. And so all of those providing support are also lost in that month of ovulation. So those are a couple of questions. I'll get back to our slides. And so we talked about how the number of eggs decreases in every month, but the quality also changes. So we are both looking at quantity as well as quality. So if you think about it, these are all the eggs we're ever going to have in our lifetime, and they're there. They're sitting there, they're not changing, they're just kind of hanging out. But over time, we face all kinds of things. We face, poor choices that some of us might have made in our youth, with like substances like tobacco exposures, driving down the freeway every single day and getting exposed to the gas fumes, things like that, diet things that are in our food supply. Everything that we are exposed to in our life affects us in some ways, and it affects our cells, including those cells that have been sitting there since birth. And so the longer those eggs have been around, so the older a woman is, the more exposures they've had. So there's more chance for some quality degradation within those eggs. Poor quality of eggs can affect not just the ability to actually conceive, but it can also increase the risk of miscarriage. And we do know that as women increase in age, the risk of miscarriage, as well as the risk of chromosome or genetic abnormalities, things like extra chromosomes, like Down syndrome, will increase as women increase in age. So I always tell people, I don't care if you're coming in to see me when you're 19 or if you're 40, you're never too young or too old to learn about your fertility and where you stand and just kind of what the process is and what you might want to do to think about how you want to grow your family and what your timeline is going to look like for growing your family. So when I talk to people about conceiving, I tell people it takes 4 things. You have to have eggs, you have to have sperm, you have to have the right anatomy for the eggs and sperm to meet and for the embryo to implant, and then you have to have timing. Timing is ovulation. So everybody's cycle length is a little bit different. And there's 2 phases to a menstrual cycle. The first phase is when a follicle is growing, and we call this the follicle phase. The end of the follicle phase is when you ovulate. There's a hormone surge that happens, and eggs are released about 36 hours after the peak of that hormone surge. Once the egg is released, it has about 24 hours for it to be fertilized. The second phase of a menstrual cycle is the 2 weeks from time of ovulation until a period or a missed period. And so that's the consistent part. So someone who has a 28-day cycle will ovulate about day 14, but someone who has a 30-day cycle ovulates about day 16, so 14 days before a period. But it's not that you have just that 1 day of ovulation to conceive. Sperm will live in the reproductive tract for 3 to 5 days. And so you have about 3 to 5 days before ovulation where you're fertile, and then 1 day after ovulation for fertility. And so it does give us, I sometimes say, roughly a week of fertile window, kind of in the mid-cycle for most people.
I was gonna say about the but I think I didn't think it was.
Oh, I think I hear someone talking, but it wasn't a question for me, so I'm just going to keep pressing on. So things that affect fertility, we sort of touched on these when we talked about egg quality things. So I got muted too. So when we talk about what impacts fertility, it's anything that affects us. So as we talked about, like the things that are in our food, whether it's hormones, whether it is antibiotics, whether it's pesticides and herbicides, any things that we're exposed to, chemicals in our makeup, chemicals in our plastic bottles when we're drinking water, fumes from gasoline. Every day we are exposed to things in our environment, and that will affect not just our skin and what we see on the surface, but it affects us inside and out. And so that can affect our eggs, egg quality, and fertility. And so while some may have more effect than others, when we think about lifestyle things, as we talked about or touched on earlier, birth control will not affect fertility other than the fact that it's delaying pregnancy because of age when we're postponing pregnancy. But then other lifestyle things will affect fertility. Smokers, for example, will have a more rapid decline in their fertility because of the effect of that smoke or even secondhand smoke on egg quality and ovarian reserve. Family history makes a difference. If you had a mom who went through early menopause, you may have an earlier menopause or have an earlier decline in your fertility potential as well. So infertility, I don't really love the word. I don't think anyone, because it sounds so stiff. I think of people as having subfertility, which means their pregnancy rates are less than others. It doesn't mean they're impossible. So the true definition for infertility is the inability to conceive or stay pregnant after 12 months of trying. So it's really 12 months of having exposure to sperm around the time of ovulation. For someone who is over 35, we actually say people have a fertility issue that deserves evaluation if they have not been able to have a successful pregnancy after 6 months of trying. The reason we say 6 months for someone who is 35 and older is simply because we know that there is this increasing decline in fertility rates. So we don't want people to postpone getting evaluated because that postponement could make things even more difficult down the road. About 1 in 8 couples will experience a fertility problem. And so if you think about it, I sometimes, when you're feeling bad about if you're having a fertility issue, I just say, go to the mall or go to the grocery store and look around, and you can be like, okay, 1, 2, 3, 4, 5, 6, 7, 8, 1, 2, 3. And then you don't feel quite so alone because you realize every day you are interacting with someone, maybe multiple people who have had some fertility struggles. They're just not advertising it and wearing it on a billboard, around their neck or something, but they are still having the same experience maybe a different path or a different journey, but it is more common than we think. 20 years ago, we didn't talk about it. I was telling someone today, we didn't talk about it because we didn't talk about sex. I know I said it out loud. We weren't supposed to say that, but you know, fertility is associated with sex. And we can talk about it now more than we used to be able to talk about it 20 years ago. So I think that 20 years ago, people thought they were more alone. But now it is not such a, you know, it's something that's common. A patient I was talking to today was telling me how she has a group of friends and they didn't get together because of fertility issues and they're all having trouble. But then a lot of times women get together and they think that fertility issues, it's just a woman's problem because most fertility issues are treating within a woman's body. But between of those couples who have fertility problems, 1/3 to 1/2 will have a male factor component. So it could be a sperm issue. If you are a single woman or if you're a woman who's partnered with a woman, obviously it's a sperm issue because you have to have sperm somewhere. But if you know, for other couples that are heterosexual couples, there could be a male factor component. And so it's not just about the eggs. The men should also be evaluated as part of the initial fertility evaluation. So this is kind of my big summary of like at the end of the day, everybody is different. Everyone's journey is different. Everyone's path is different. Everyone's experience is different. Everyone's hormone testing will be different. And so the only real way to know where you fall is to get evaluated, to go have a conversation to find out what your status is today. So we have our fertility assessments, and a fertility assessment is really a first step. With the fertility assessment, you will have a consultation with a specialist, and this can be done virtually, just like we're having our Zoom call today, or it can be done in person in the clinic. If you are in the clinic on the day of a fertility assessment, you would have an internal ultrasound that will actually look at what's called an antral follicle count to kind of get an idea of how many follicles are kind of sitting in your ovaries, sort of in that pool that woke up that month. And you will get some blood work, including an AMH, which is anti-Mullerian hormone, to take a look, another assessment of looking at your ovarian reserve. If you have a virtual visit, you would have the conversation first, and then at some point in the future, we would schedule the ultrasound and the blood testing in the clinic. So when we have our fertility assessment, it all depends on where someone is in, what phase in life they're in. There's options. We could do fertility treatment if someone's like, I want a fertility assessment because I want to know where I am because I'm getting ready to start treatment. Some people just want to have an assessment because they want to know where they are because they're planning to get pregnant next month or start trying to get pregnant next month. And then some people want to know where they are because they're like, well, next month's too soon. Maybe next year's too soon. Maybe 5 years from now is too soon, but someday I want to get pregnant. So we have options of doing fertility preserving things such as egg freezing for women who are not partnered with men, or embryo freezing for women who are partnered with men. So let's talk about what egg freezing is. So egg freezing is a pause button. We know that a woman's fertility is tied to her age. When we have eggs, fertility is tied to the age that the eggs are when someone is planning to conceive. So if I have eggs from someone who is 30, but I use those eggs for that same person when they are 40, their chances of conception are based on the age 30 when we have those eggs retrieved. So egg freezing gives us the ability to kind of put a pause button on while we're going about age. We are building careers, traveling, all of these things that we don't want to conceive. We can keep these eggs on reserve instead of losing them every month. So it's the process of actually removing eggs from the body, removing them from the ovaries, and freezing them so that we can thaw them for later use. So for people who are thinking, should I do egg freezing? It's kind of ask yourself a few questions. What is your age? How many children do you want in your ideal family? And the reason we ask how many children is because pregnancy you're still aging while you're pregnant. So for someone who tells me at 35, they want 3 children, if I assume they get pregnant at 35, they deliver when they're 36, get pregnant when they're 37, deliver when they're 38, they could be 39 when they're trying to have their 3rd child, and we know pregnancy rates will be lower. So for people who want large families, egg freezing may be an option to get those eggs now so that you have them for later use when it may be harder to get pregnant for the 2nd or 3rd. Also, what age do you want to be when you have your first child? You know, do you want to be 40 because you have a certain goal of things that you're trying to do, things that you're trying to meet before a certain point, and, you know, people draw out their life plan and they're like, this is when things are going to happen. Well, at 40, it might be more difficult than it would be at 25. And then, you know, sort of as we touched on with how many children that you would ultimately like to have in your family, what age do you want to be when you deliver your last child? Because if you say that your last child is you want to have at age 45, we know it's going to be more difficult for most people to get pregnant at 45. And so you may want to consider egg freezing when you're 35 to get that option for later on. Okay, so people always ask, well, how do you freeze the eggs? Well, some of the freezing process is kind of high-tech science in the lab. But before that, we have to get the eggs. And this is all about ovulation. Ovulation is when the eggs are released. So we talked about this when we looked at ovarian reserve count and what ovarian reserve function is. But every month, your body recruits this group of eggs that start growing within the follicles in your ovaries. One of them is selected to be mature, and the others provide support, and they are lost. So what we do when we're egg freezing is we're very opportunistic. I did see a brief question that popped up in our chat about when you do something like IVF, do you lose your eggs more quickly? And the short answer to that is no, because what we're doing is we are providing the support that those support eggs would be doing for the one dominant follicle. And then we're stimulating those support follicles to grow also. And so we are stimulating these eggs to grow, and then we are retrieving them, but we're retrieving the ones that woke up on their own. The same ones that would have woken up and been lost if you ovulated, we're just taking them and saving them for later. So it's the same number that you would lose whether you ovulated one, or the same number that it's removed from your ovaries when we're doing an egg freezing process. And so some people say, okay, so I think I said this before, we are opportunistic. We're getting the eggs that your body would have already chosen to be the support ones. We're just trying to get them to mature to be the ones that we can freeze for later. Okay, so now let's talk hormones. So your body, so in the pituitary, which is a gland in the base of the brain, your body produces a hormone called FSH. FSH stands for follicle stimulating hormone, and it does exactly what it sounds like. It stimulates follicles to grow, and as the follicles are growing, that's where the eggs are maturing. Your body's natural process to produce one egg sends a feedback system to the pituitary that says, hey, I'm responding, I'm making an egg, you don't have to send me more FSH. Well, we're going to override that system when we do egg freezing or IVF, and you're actually giving yourself shots of FSH, so you can't override that system. And you're doing these hormones for about, I say 10 to 12 days, at the beginning of the cycle, and that part of the cycle that we call the follicle phase, that follicle growth part, the first half of the cycle. You're giving yourself the FSH so that we can stimulate that one, as well as the support ones, maybe not 1,000, maybe like 10, but we're trying to get some of the support eggs also stimulated. During that time, because we need to make sure we do things in a safe way, but also because timing is really important for ovulation, we do frequent ultrasound monitoring so that we can see how well you're responding to the medication. Do we need to increase the dose, decrease the dose? Is it time to sort of trigger for ovulation so that we know when to retrieve those eggs? And so we have to time that pretty precisely. So we do lots of ultrasound monitoring and blood testing during that roughly 2-week window. So Timeline, we talked about it's 10 to 14 days, which is the hormone injections, the ultrasound, and the trigger shot. This is kind of what a calendar looks like, and it's nice. We have, visuals so that you can, it's not just words. You're like, oh yeah, today's a shot. Oh yeah, today's an ultrasound day. And then the final shot that you do is we call it a trigger shot, because it's triggering ovulation, and it's mimicking the peak in that hormone surge that your body would create when it's ready to ovulate. So that is the one shot that the timing is really, really precise, because we know that you ovulate 36 hours after that hormone surge. We can't let you ovulate. If you ovulate, those eggs are too tiny. We can't see them. We can't find them in your body if they've been released from your ovary. So about 1 hour before you actually ovulate, so 35 hours after the shot, we do an egg retrieval. So the egg retrieval is done in the clinic. It is a procedure where you are under sedation, just like all of the internal ultrasounds we've been doing for the 2 weeks leading up to the egg retrieval. You have an internal ultrasound. The reason you want to be sedated is because there's a needle that's attached to the ultrasound that passes through the vaginal wall into the ovary, and it sucks all the fluid out of all of these follicles. It's in that fluid that our embryologists sort through it very diligently to find the eggs that we have retrieved. This is a light sedation. It's a twilight. You're asleep, but you're not like deep anesthesia sedation. People are able to breathe on their own. Sometimes people talk to us, they don't remember a thing that they've said, but it's enough that you're comfortable. So I do always talk to people about difference between egg freezing and embryo freezing, because the process that a woman goes through is exactly the same. The difference between egg freezing and embryo freezing is what happens in the laboratory. With egg freezing, we just freeze the eggs. They can stay there until they are ready to be used. And when they're ready, we thaw them, we fertilize them, and we grow them to embryos. With embryos, they've been fertilized with sperm and grown to embryo before they are freezing. There's pros and cons to both. I know that not every egg is going to actually be a mature egg that will successfully fertilize and grow to an embryo. So there is a drop-off. If I freeze embryos, I know exactly what that drop-off is, so I know how many embryos someone has, and I have a better guesstimate on what their chances of a live birth would be from embryos. There's a major drawback to embryos, and that is that you can never take the sperm out of an embryo. If something were to happen, like a relationship, we never want to think about this, but if relationships end or change or accidents happen and a woman is no longer with the male partner, she can never have that flexibility of taking those the sperm out of the embryos and maybe conceiving with a different male partner in the future. Egg freezing allows that ongoing flexibility. Another benefit to embryo freezing is that we do have the ability to do biopsies of embryos before they are frozen, to do genetic testing on them. And so sometimes having that genetic knowledge, whether it's gender, whether it's just knowing chromosome balance, making sure there's not extra chromosomes or missing chromosomes, you have that knowledge with embryos. So I always say embryos give you knowledge, eggs give you flexibility. So eggs or embryos, if we have done fertility preserving things where we have frozen them, they stay frozen until they are ready to be used. My hope for everybody who's doing any fertility preservation options is that we don't ever have to use them. I know that sounds really terrible. It's like, why would I go through this if I'm not going to be using my eggs or my embryos? I want people to get pregnant on their own. But the good news is if you get pregnant on your own, then later on down the road, when you are ready for baby 2 or 3, and you've had that increase in age or fertility rates are lower, you might still have these embryos or eggs as a backup plan. So IVF is really the same as the egg freezing, embryo freezing, except, well, I always say the egg and the embryo freezing, it's the first half of IVF. The second half of IVF is where we're actually transferring an embryo into the uterus. So, oops, we went backwards. There we go. So when we talk about so that's sort of like our fertility preserving types of things. But many patients are coming to us not because they're wanting to preserve their fertility for the future. They're wanting to be pregnant not tomorrow. They wanted to be pregnant yesterday or tomorrow. So there are different paths that people may take for treatments. Some people will consider doing some natural, try to conceive on your own for a few months, or try and do medication to improve ovulation or increase ovulation with timed intercourse. If people are needing treatment, we have the option of doing IUI, which is intrauterine insemination, or sometimes artificial insemination. Basically what that means is we're taking sperm, concentrating it, putting it into the uterus so that more sperm are actually in the uterine cavity. Normally through intercourse, a small amount of sperm gets into the uterus. And I always say, men don't always ask for direction, and sperm are like manatees. They can't swim backwards. The cervix is not a straight path. There's lots of little glands and crypts and things. And so when sperm is trying to get from the vagina into the uterus, it has to bypass the cervix. If the sperm takes a wrong turn into one of the crypts, it can't get out. If we bypass the cervix altogether by doing the insemination, all of those millions of sperm are getting into the uterus. So it's like having more arrows to find the target of the egg. We can use donor sperm for single women, or for women who are partnered with women, or for women whose male partners don't have sperm. If we want to step up the game a little bit more, increase our technology, we have IVF. That's, the whole process that we talked about with egg freezing. It's just the fact of transferring the embryos. We can use donor eggs for women who may not have a good ovarian reserve, or they're advanced reproductive age and aren't really making a whole lot of eggs on their own. We can use donor sperm if necessary. We can use, it's like, I was about to say another reason for donor egg, and I can't remember what it is at the moment, but there's lots, we have options. And, with ovulation induction, that's just using oral ovulation medications. Sometimes the idea is if someone has a condition that causes them not to ovulate, like polycystic ovary syndrome, ovulation induction is to get you to ovulate. For women who do ovulate, ovulation induction medications may increase the number of eggs. Usually we're looking for like 2 to ovulate, but that increases the number of targets to increase pregnancy rates. And then we have options for people who are coupled with someone of the same gender, and there's not a male and female in the relationship. So we can use egg donors for men coupled with men. They would also use gestational carriers to carry a pregnancy. And we can use sperm donors for women who are coupled with women. So kind of next steps, it really depends on where someone is in their journey, in their path. If someone's trying to get pregnant today, they might want to know, and they haven't been trying long, they might just want to know what their fertility status is. If they're wanting to get pregnant tomorrow or someday in the future, they may want to know where they are so that they have some idea of what their timeline might look like. Is their ovarian reserve a little bit less than they would hope for? Then they might want to move a little quicker. Or do they feel like, wow, I've got this really robust ovarian reserve. I'm just going to come back in a year and see if anything's changed. Wherever someone is on their path, it doesn't hurt just to learn about where you are today so that you can make your plans for the future. Okay, so this is never the fun part. This is the financial part. I always say fertility treatments. Hopefully, if everyone, if people have employers that are providing the fertility benefit, it may not be so costly. We do have a discount code for the month of December. And so if someone has not already booked appointments, or even if they have, they might be able to put the discount code in. Our normal and prices that we have listed, these are sort of our cash prices. This is what it would be for someone who does not have an insurance benefit or an employer benefit. And we do offer discounts. You know, because you came here today, this is my special discount for the month. And lots of insurances. And so if you are scheduling an appointment with us or scheduling treatment, you know, we would obviously see what your insurance benefit provides. People who do have copays, you know, it's January coming up soon. And so people's deductibles and copays may start all over in January. But if you have your FSA and you're trying to get it in before the end of the year, we're a good place to use it. Okay. Well, I always feel like these conversations, like we cover a ton of information in just a couple of minutes. I saw a lot of things in the chat that I didn't have a chance to look at. So hopefully we can answer some of these questions.
Yes, wonderful. If it's okay with you, I'll just read off some questions from the chat. I'll start with ones that we just received. Does Kindbody freeze sperm for IUI? I can answer that one. The answer is yes. This one, can you turn frozen eggs into embryos in the future? And what does that look like?
That is an absolute yes. That's the reason we would freeze eggs. What that looks like is really, you've already done the first half if you've got frozen eggs. What we do is we thaw the eggs and then we fertilize them in the laboratory, grow them to embryos. Depending on someone's timeline for when they want them transferred, they can either be transferred as a fresh embryo from a frozen egg because they were thawed, grown, and then transferred. Some people will thaw the eggs, fertilize, grow to embryo, and then refreeze the embryos. And then later when they're ready to use those embryos, they can thaw and transfer. The transfer process does require some timing with the cycle because there are receptors on the endometrial lining that have to wake up at the right time to accept an embryo. And so that may mean that we give you some low dose oral hormones for about 2 weeks to get the lining just right and the hormone balance just right for the receptors. We add progesterone. And then when we've got things mimicked like a cycle and we've got the optimal hormone timing, that's when we would do the embryo transfer. Embryo transfer is a small, skinny little guide, passes through the cervix into the uterus, and under ultrasound guidance, we can actually sort of we can watch where we drop the embryo into the top of the uterine cavity.
Great. Let's see. How does PCOS and the follicles factor into your fertility as you get older? This one's a little bit more specific on a condition, but.
So this is a really nuanced one. PCOS is, and I say this, PCOS is a bitch. It's tough because women who have PCOS, what happens is every month, well, the communication between the base of the pituitary that releases FSH and the ovary and that back communication, it's not, somewhere or another, there's a miscommunication. So every month with PCOS, what happens is that group of eggs wakes up, but there's not one that's selected to be the dominant one to ovulate. And so they're not lost. And then the next month, another group wakes up. And so what ends up happening is over time, you have these polycystic ovaries because you have all these tiny little follicles that have woken up. It affects fertility in 2 ways. One is you don't ovulate, but then when we do get you ovulating, some of these follicles that may ovulate have been around for a while. And so their quality may be degraded and it can increase miscarriage rates. The good news is people who have PCOS do not have a more rapid decline in their ovarian reserve and fertility potential. So it's kind of a nuanced question because it affects fertility and the ability to get pregnant today, but it does not affect long-term fertility potential. I hope that answered the question.
I think so. What's the best way to check that you're ovulating when you have infrequent periods?
Oh, see, this ties into the PCOS question, and this is a really, really hard one. The only way, so ovulation, we talked about the cycle. It's 2 weeks before a period, and that follicle phase is variable. For someone who has infrequent periods, you can do ovulation predictor kits. And so these are like the urinate on a stick kits that say, and when the color changes, it's similar to a pregnancy test. And you're like, this is the day that the hormone surges up. They can sometimes be very difficult, especially with people who have PCOS, because one of the hormones that is tested in the ovulation kit is sometimes high for people who have PCOS. They look like they're ovulating every day when they're not. And it goes to that whole like ovary, brain, ovary communication cycle. The best way to check if you're ovulating, if you don't have regular periods, unfortunately, is by looking with an ultrasound, which means visits to the clinic. If you're trying to conceive on your own, that's not really feasible. And so I just say have intercourse twice a week, and you're probably going to hit a fertile window sometime. But if you are trying to get pregnant and you're actively doing things, doing treatment, for someone who has infrequent periods, I would be recommending ovulation medications and ultrasound to sort of time that ovulation window.
I think this person will be very happy with your answer, but can you do a fertility assessment with an IUD in? And at what point does the IUD need to be removed?
We can do a fertility assessment with an IUD, no problem. We can do an ultrasound with an IUD, no problem. We can do egg freezing with an IUD in place, no problem. You need to have the IUD removed at some point when you are ready to put an embryo into the uterus.
Great. What's the probability that all of the eggs frozen will become a viable embryo?
Tough question. It'll be different for everyone, sometimes based on age. The likelihood of every egg being a viability embryo is probably less than 1%. We know that not every egg makes an embryo. In general, we feel like a good number of eggs to feel like you've got a really good chance of having a live birth is about 10 eggs. So I tell people, so sometimes people will go through more than one egg freezing cycle to make sure that they have enough to give them a good chance to have multiple children. The younger you are, the fewer eggs that you need, just because the egg quality is better when you are younger.
Great. Do alcohol and cannabis affect egg reserve quality in the same way that tobacco does?
Great questions. The answer is mixed. So smoking cannabis, we know that the chemicals that you get from inhaling smoke are going to definitely make an impact on your egg quality. Edible, we're not as sure. We don't have the evidence yet to say that it does not impact things, but we also don't have evidence to say how much of an impact it would have. So I sometimes say absence of evidence is not evidence of absence, which means not knowing doesn't mean it does not hurt. We just don't know. Alcohol, we do think really, also a little bit mixed. A little bit is okay. And it depends on what people think is a little bit. I once had a patient say, I don't know how much is a little. You might think he said, I think what his answer was, what I think is a little, you might think is a lot. But in general, we feel like if people have 4 alcoholic beverages a week, it's not going to affect their fertility potential. But when people are starting to have heavy drinking, because of all that exposures of other things that often go along with heavy drinking, we do think that there is an association with a decrease in ovarian quality with heavy drinking. For a week, that's, like 1 every other day. That's not so heavy drinking. But the problem is we don't know what the threshold is. Where does it become too much? Is 1 a day okay? Probably. 6 a day? Probably not. But what about between 1 and 6 a day? We don't know where the threshold is. So I tell people everything in moderation, like the good Episcopalian that I
am. Let's see. Does an AMH of a 0 mean you're completely out of eggs, or is the egg count just too low to register on the blood test?
too low to register on the, if someone still has periods, there's still eggs in there. It's just too low to register on the test. And unfortunately, it means that we don't have anything that's going to stimulate and successfully to try and find those few remaining eggs that may be there.
Let's see. How much does it cost to store retrieved eggs? How long can you keep them frozen for? I will answer the cost question. It's $600 a year. Oh, I see Kennedy answered that too. But how long can you keep frozen eggs for? Is there any sort of threshold there?
We will not transfer embryos to a woman over age 55. So as of right now, we do not think there's a limit on how long they can be frozen, but each woman has a limit as to how long she can keep her own eggs frozen.
Do ADD meds or antidepressants affect fertility in any way?
Not that we know of.
Do more frequent periods, heavier periods mean we're losing more eggs?
Heavier periods, no. Frequent periods, maybe. For someone who is having periods more frequent than every 21 days, or I would recommend that you have an evaluation to find out what's going on, because more frequent than every 21 days is too frequent.
Right.
And it may not be related to ovarian reserve, but it may be related to other things that need more exploration.
Wonderful. Thank you. Let's finish off with this one. I'm a 30-year-old and was told I have very low AMH levels. Is there any medications I can be taking to maintain mature the eggs I currently do have?
So this is a really great question and a hard one to answer. If the AMH is low, that is not, a lot of times we get tests like you're testing for diabetes and you're like, okay, well, I can take a medication and that can make my diabetes better. Unfortunately, when we are testing for ovarian reserve and testing AMH, it's a reflection of something that's already happened and we can't reverse the clock. We can't turn it backwards. So for some, the good news is egg quality is actually better, even if egg numbers are low in younger women, compared to this. So a 30-year-old with a low ovarian reserve will have higher pregnancy rates than a 40-year-old with the exact same AMH level. What I would advise someone who is 30 who has a low AMH is time matters. So this would be the time that you really do want to not necessarily take medications to get the AMH better, because we can't get more eggs, but this is the time to think about doing a fertility preserving type of options. Get these good quality eggs while we can.
Great. Thank you. There was a ton of great questions, a handful we didn't get to tonight. I saw a handful on surrogacy and donor eggs and donor sperm. We have a couple great, very specific virtual events that are all recorded on our YouTube that go into detail on those kind of parenthood paths and journeys. So highly encourage you to go watch those ones. They will answer 99% of your questions, and any questions that can't be answered, our team is always available at navigator@kindbody.com. Kennedy here is lovely, and she's one of the ones who will help answer your questions there. So please reach out to us. Dr. Henne, go ahead.
I did see a few quick ones that popped up that I wanted to answer real quick. How many days should a man abstain before semen analysis? I say 2 to 3 days. And I saw one question at one point. It says, what about two women who want to conceive together? And yes, absolutely. We can do what's called reciprocal IVF, where one woman goes through the first half of IVF to retrieve eggs, and the other woman will actually carry the pregnancy. And that is something that we can do here. And that's one of my very favorite things to do for people.
Great. Wonderful. Dr. Henne is in our Minneapolis clinic. You can book an assessment there to see her in person and meet the wonderful team. We are in 11 markets and hopefully and opening up a ton more next year. So be sure to subscribe to our newsletter to stay on top of all Kindbody fertility news. Thank you, everyone, for joining us tonight. We appreciate it. Thank you. Thank you. And we hope everyone has a great night, and we will see you in a Kindbody clinic again soon. Thank you all. Thank you.
Thanks for joining us.
Thank you, Dr. Henne. We appreciate you.